we'll take the rest of the topics. Before I go to the other giants, amongst the geriatric giants, there are a few diseases that I want to ask her about and how they should be differently managed in the elderly than in the younger population. So, how is it different to target TSH in hypothyroid patients in the elderly? What makes the elderly different?
Hypothyroidism, especially the subclinical variety, is a disease which has been made into a worse disease by doctors. When I say that, somebody has, if the lab value is 4.5, no? I have seen, not talking about the elderly here, if it's 5, the cardiothoracic registrar has already started the 80-year-old on Eltroxin. So I told him, what are you doing? Hey, it's above the lab value. I said 0.05 higher, and I use the analogy of a bullock cart, that is my 80-year-old, being attached to a high-octane jet fuel and dragged along, the bones will break. Okay, we don't want the metabolic rate to be so high. Please stop it. So I think, on the other hand, if you, even subclinical hypothyroidism untreated can give rise to cardiovascular disease and atherosclerosis. So we have to play between these 2 points. If you give too much of thyroxine, not the extreme of what I said, bullock cart, but you will promote atrial fibrillation. You will promote osteoporosis. And they will happen so subtly, nobody knows at the end of it. In fact, some people in America are thinking whether the high level of atrial fibrillation, which anyway the aging atria will do, and you are promoting it by perhaps giving this. And I have seen patients who are in this dilemma, and so I'm very cautious about starting. So subclinical hypothyroidism, where your T4 levels, free T4, total T4 are normal, and your TSH is somewhere below 10. The standard teaching is, do not do anything, because if you want to do another lab test, you're very, it's a young female and all that, you can do the antibodies, okay? Do the TPO, because if the antibody is elevated, then they've got Hashimoto's, and they will progress, don't have to wait. If they are antibody negative, please wait for 6 months, unless it's, they've got a lot of symptoms also. If people have symptoms, because our lab tests are not that accurate, so they've got this weight gain, they've got everything else, and especially if they've got dementia, in the elderly, hypothyroidism and dementia, then go ahead and treat, but not everybody. So I don't know whether I have a particular value, but after 6 months, if the hypothyroidism, even if the thyroid level is normal, you can treat, because it will progress. So that's all that I have to say. In pregnancy, and of course, who all are treating children, I don't know. Hypothyroidism in children must be treated by an endocrinologist, because all to do with bones, growth, it's too complex. Hypothyroidism in pregnancy, please don't bother. Give it off to somebody, because, if you give too much, and the reverse also true for thyrotoxic. Any thyroid disease in pregnancy, very close monitoring, because its effect on the fetus is there. So that is all I can say. Do you have anything else to say?
I think that what you said is just perfect. What is the difference in diabetic drugs in the elderly, in the very old especially? What diabetic drugs should we avoid? What should we give?
So nowadays, the sulfonylureas, which is what we grew up with, they came like a flash out of the other drugs, what were they? First generation? No.
Tolbutamide.
Tolbutamide, chlorpropamide and all that. Then the glibenclamide came. In 5 milligram doses, they just made sure everybody became all right. Now they have come into disrepute because of their metabolic problems. Not not these don't give metabolic problems, sorry, the diuretics.
Hypoglycemia.
But they give rise, they're very long, the glibenclamide is very, very long life, long half-life. So that 100% must be not given to an elderly person, but having said that, it's the cheapest drug. I don't know what the cost is, but it's the cheapest drug. So if you've got a down and out person who's diabetic, please give him a lower dose because it's like water. You can't give him gliclazide, which is hellishly expensive, but is the best sulfonylurea apart from glimepiride. Glimepiride, again expensive, but it has, it's good because it has got extra pancreatic effects on the muscle. It promotes what they say, I don't know whether it's the glucose 4 transporters, GLUT4 so it allows intake of glucose. Do you agree with all that?
I don't know this.
You don't know?
I don't know
Okay.
this.
So it has an extra pancreatic effect. So glimepiride is the thing. When it first came, I didn't like it. You know, there's a thing about liking medicines being biased against some medicines and being, you know, like sambar. One of my teachers told me, if you're making sambar one way and it turns out good, why do you need another way to do it? So that's not a good idea. We should embrace new things, but we shouldn't go with the latest drug, the new fad. Why? Because it may have some side effect which we don't know. In phase 4 surveillance, it may come out. And don't be the first one to start a very new drug unless it's something great. Let other patients get the complications and then you give it. So
I think that is a very good instruction for us. A new drug comes, say semaglutide, for example. It came, semaglutide is GLP, 1RA. Say semaglutide has come, it is in the news, etc., and you are tempted to give it. Wait for 6 months, 1 year, 2 years. Let others give it. You see what happens now. Semaglutide we know can cause intestinal obstruction. We know it can cause pancreatitis. We know it can cause worsening of retinopathy, proliferative retinopathy. These things will gradually come up. These are rare side effects, and still semaglutide is a bestseller all across the Western. But we should, as she said, let others get the side effects and our patients be safe for some time.
But coming back to the drugs, so long-acting sulfonylurea is out. In general, the present recommendations are to use sulfonylureas as the last resort before giving insulin. But having said that, I'm used to metformin first, then sulfonylureas, then DPP-4 inhibitors.
How's your insulin use in the elderly?
Yes. So, and then insulin, we used to say, oh, this insulin. But with the newer insulin, especially the long-acting glargine, see, all of these has come after I have become a geriatric physician, okay? But still one has to learn on this thing. And I was very reluctant on this nocturnal insulin. How to give insulin at night when he's not eating, will have hypoglycemia. That's all rubbish, okay? So this, all of you know this already, but I had to, one thing about medications, you have to get it into your DNA. You have to be confident that no matter what they write, you are comfortable because you've been making sambar in one way. Suddenly they say Lantus. So it took me a while, but now I will say Lantus is wonderful in an older person, slow acting, and by the time this diabetic has had so many years of diabetes, he's come old age, his pancreatic beta cells have fallen out completely. So he needs insulin. You can't flog the beta cell anymore with your oral drugs. So I'm very happy with Lantus. I'm a very wary of supplemental short-acting drugs. What do you call them?
Rapid-acting insulin?
Analogs, insulin analogs. Yeah, rapid-acting. I'm very wary of them because hypoglycemia in the elderly is a more severe danger than complications of hyperglycemia because they're not going to live very long. Do they have long time to develop complications because of this thing? So the targets have been revised. Now remember, that's why you have to have a healthy for the research that comes out. So they said 6.5. You cannot, hemoglobin A1C. You cannot make an 80-year-old 6.5. He'll die of hypoglycemia. So it has been revised now. 8%
In the
is
very old.
Very old. 7.5 to 7 in our age group, 60, 70. And for the younger person, strict 6.5. There's no doubt about it, because you've got so many more years to live, so many more chance to develop microvascular complications. Now I believe even macrovascular complication due to sugars alone, because we used to say macrovascular is not due to sugars alone, because there are so many others, hypertension, cholesterol, etc. But the microvascular is definitely dependent on your ambient glucose level over a long time. So I think as a healthy rule, a common rule is look after the person's diabetes, but not as vigorously as you would for a younger person.
What is your comment on statin use in the old or the very old?
Yeah, we
What
did
is
that
your-
in this thing. So don't start a statin as a primary prophylaxis in somebody above the age of 75. So the first time he may look healthy and fit, and whatever he had came for his regular master health checkup, and the cholesterol was 250 or 300 or something. So after 75, why do we say this? Because it's a prophylactic. He's going to get a heart attack, but what's his longevity? At 75, in our Indian standards, not going to live more than 5 years. Average person. So you don't want to give a drug which is going to cause side effects. Supposing he's not diabetic, he may be pushed into diabetes by your use of statins. And then he may be the unfortunate one who gets the myopathy and all that. So universally now accepted unless there is some other overriding factor. That is, he's already got peripheral vascular disease in his legs or something, you see. And he's got this, that and the other. And he has a cholesterol of 300. Then of course, yes. In general, I also find that people just look at the cholesterol level, even in younger people, and start the statin. If it's anywhere 201 also, they will start. No, you have to look at what is the cardiovascular risk in 5 years, 10 years if he's never had it. If he's got the he's got the 5 important risk factors of family history, obesity, smoking and all those things, then at a lower level itself you can start. But if he has no risk factors, then cholesterol alone is not an indication for starting statins. You have to do non-pharmacological and then. So I think those are the general rules which you're all well aware of. I think statin is overused. On the other hand, I feel statins is a fantastic drug because it's really cut down cardiovascular atherosclerotic disease to a great extent. But we have gone, because my personal feeling, which I'm anti-pharma, is that we are pandering to the pharma industry, and when they raise the level of cholesterol over consensus, they fly people into some nice lovely island and come to a consensus meeting that from 200 we will raise to 200 and we will reduce to 190, finished. It translates into billions of dollars. So please we should be realistic.
One lesson that we can learn from this is in primary prophylaxis for dyslipidemia, if a patient comes to you with a health checkup, is 75 plus, there is no atherosclerotic cardiovascular disease so far. If this patient has an LDL cholesterol of 190, LDL of 190, which is a recommendation for a younger person to start a statin. At 119, a 75-year-old do not start a statin. Now, another debate will be if the patient is diabetic without any atherosclerotic cardiovascular disease and at 75 or plus, you find an LDL, should we start a statin for that patient? I don't think research gives an answer to that. But would you start in a diabetic who's 80 years old with an LDL of 140? I'm asking her because I think our answers might change.
At the moment, I don't think an 80-year-old, mainly because the effect of your cholesterol reduction is going to have the atherosclerosis not then, but later. He's a diabetic, I agreed. He's got, remember there were days when the moment you were a diabetic, the moment you were a hypertensive, you were started on antiplatelet medication as primary prophylaxis.
Aspirin.
That's gone now because aspirin caused more harm. Statins anyway have got so many things against them. Why do we want to give a drug to an old person and harm him? Remember, every drug can have the potential to harm. Why should we harm him when his lifespan is limited anyway? Why should
I think the argument should be that somebody above the age of 75, diabetic without any history of atherosclerotic disease, the argument might be this, that if you give a statin, then you're causing muscle problems, you're potentially causing worsening of diabetes, and your benefit will be seen over a 10-year period, and that itself might not be a great thing to do. So we might have to gradually become more conservative in our statin therapy than we are currently.
And as you have said in your little thing booklet, that rosuvastatin is much better than...
Yeah, that I think we know that atorvastatin and drug interactions are significant. Yeah, ma'am, last. Yeah, we will come to that. We are just going to discuss that only. So, use of fibrates in high triglycerides as a general rule on in the elderly both. What is your...
As a general rule,
is it
yes.
overused?
If it's, I
Fibrates
have
are
not
overused.
seen it being over. In fact, I think it's underused.
Fenofibrate we are talking about.
Yeah. Most people just give cholesterol. And actually the triglycerides are definitely in a type 2 diabetes. The dyslipidemia is more in terms of the triglycerides, which have their own morbidity. So, yes, it makes sense. But the moment you combine fenofibrate with cholesterol, the myopathy, with statins, the myopathy is much more increased. So I would restrict fenofibrate to when you can't, even the statins alone will bring down your triglycerides a little bit. So unless it's 700 or something like that, I would first try with they'll always have some cholesterol elevation. I would start with the statins. If it doesn't come down, then I would add fenofibrate.
What is your take?
How about other things like ezetimibe and now this new PCSD?
Yeah, so in the we have probably studied
You've
that.
studied it, okay.
So bempedoic acid, ezetimibe, and I don't know how.
PCSK inhibitors.
PCSK9 we don't have experience with
That,
inhibitors.
Yeah,
but
don't have.
okay, so that is about. Let's go then to treatment targets of a few things. Yeah, Yanni, we discussed that HbA1c, etc. We did discuss. Okay, I think one area that I wanted to discuss is menopause, which is not in this list. What are the problems related to menopause and...
Menopause is, it's because it happens to women who are long suffering, used to disability. We haven't made much of a noise about it. But if this was happening to men, they would have changed the world. They would have all... But we women, we suffer from this. So menopause, there was a time you all remember when we were giving hormone replacement therapy to every woman who on the verge of menopause, and suddenly women were looking young forever. And I thought to myself, how dare we, I'm very conservative, how dare we play with nature? Nature says you must have menopause, and now you're reversing it. Just because you want to stop bone fractures. It was basically iron heart disease and all those things. But it's unphysiological. So I never gave my patients hormone replacement. But in front of me, I saw menopause clinics, bi-weekly clinics, then daily clinics, and they were filled with people who were then put on to hormone replacement. And then, of course, that one study, the Women's Health Initiative study came, and overnight the menopause clinics stopped, okay? Because there was higher incidence of heart disease. There was higher incidence. I mean, there was no, even though breast cancer and DVT, we all knew was going to happen, but heart disease was there. So my take on menopause is that all your patients you must look at all the somatic symptoms and all the mental health symptoms. You must be aware of it. And when your patient comes, we have to handle them as far as possible with non-pharmacological approaches, but some of them will require hormones. And our gynecologist, when I want to give, if they don't have a uterus, you can safely give them estrogens, but if they have a uterus, then you have to give the progesterone and all those things. I would happily give to my patients and send them to the gynecologist to do a surveillance. The gynecologist would tell them, this doctor is giving you this precancerous medication and all that, and you please stop it. So there is that tussle between the gynecologist and us. And so if somebody is having unbearable hot flashes, they can't function. Some people have a little early menopause, you can give them. And certainly if they've had a hysterectomy, they should have, if they're very young age, but the gynecologists never do it. So we should give hormone replacement, but proper surveillance. The other thing of, insomnia, depression, very common at the time of menopause. I'm not looking at the cosmetic things and all, but there are a whole host of issues for menopause that we should look into. And one of the things is the vaginal atrophy. The vaginal atrophy, of course, for the sexual thing, because the male libido would still be there, can create a lot of problems in a marriage. And the question of vaginal estrogen. So not only the sexual problem of dyspareunia, but also the urethra actually goes inside with the atrophy of the labia minora and all that. And that gives rise to a lot of colonization and frequent urinary tract infection in a menopausal person. Without infection, they have severe dysuria, vaginal spasm, and one thing which I found out was also gives rise to vaginal discharge. We usually think of vaginal discharge as being due to infection, either candida or trichomonas or your bacterial vaginosis or those kind of things. But pure vaginal atrophy also can give rise to a discharge. I mean, usually there's proliferation of thing, but you keep treating it with your pessaries and all that, it just keeps coming back. The discharge can be very annoying. So be very generous with the use of vaginal estrogen.
Vaginal estrogens.
Local estrogen is an answer, and I can tell you that the gynecologist, one gynecologist, when I said, how much do you use of this estriol and Premarin, she said, is it available? Which told me that she doesn't use it, because I use it freely and regularly for all my patients. My nurse knows to teach them how to give it. The only difficulty is, what is the cycle to give it? Everybody's got their own cycle, okay? So whatever you do, there's a cyclical one, that means you give for 2 weeks, then you stop for 2 weeks, and one is you give regularly for 2 weeks, then you give on fortnightly. There are many, many. So up to 1 year it takes in tapering doses to build up the vaginal epithelium. And the patient will slowly, all these symptoms will go. They'll go away to the extent that they say, so I said, all your urinary burning, everything gone. I never had. You see, they've forgotten completely. You see, don't let them forget it. Because after 1 year, what happens? So I've read up the literature on this, and it says there really may not be any harm, but there is no published work to say that there's an increased chance of vaginal malignancies. Of, not uterine so much as vulval and all that, or even maybe uterine malignancy. So there's no study. But if you look in blogs, they will say, how can you just give for 1 year? After some time, again, it'll atrophy, no? So you need to keep telling the patient, keep it with you, and the moment you start getting those symptoms, just take it. Even once in a month may be enough to maintain it, but there's no published literature on this. But this is what I do, and I have not yet come across. Again, that's anecdotal, but this is what my patients do.
May I ask you again, what is the dose you use for vaginal estrogens? Any idea that you can give us? Or a frequency of dosing?
0.1%, I think I'll have to look that up. And the applicator has got that, which will deliver just that dose. 0.5, okay, whatever. Yeah.
And you would give it how many times a week?
That's what I'm saying. So in the beginning, it'll be daily for a month. Then alternate days. For the first 3 months, it's quite frequent. After that, you slowly should come down after 6 months to about once in a month. So you write it down. I have one schedule. And I get confused about it myself. So, but it doesn't really matter. So long as you're giving it high dose in the beginning, almost daily, but in the second, third month, you're making it bi-weekly, then once in 2 weeks, then once in a week, then once in 2 weeks, and once in 3 weeks, like that. And at the end, you'll be giving only once in a month. And then after 1 year, say, okay, give it a break. And if you get any symptoms, restart it. Just.
We'll go to the next two, but before that, any questions on the topics discussed so far? Yes, sir. Now we spoke about not giving new statin in a 75 plus person. In a person who's had angioplasty done before the age of 75 and still on statin, do you continue statin or you discontinue statin? Yeah.
Hello?
That was the commentary that they started.
Okay, okay. So yes, so the answer there is a little difficult because generally we do continue it because it's not now a primary prophylaxis, okay? It is prophylaxis, secondary prophylaxis, and the fear is that the plaque which this person may have still there could somehow get activated and rupture by your withdrawal of statin. So I'm very scared to do that. But
Yes.
sometimes there are 90-year-olds and he's on his deathbed almost, you know. What harm is there? Yes, yes, if you have, there are many people who usually have problems, you know, like some mild aches and pains, you don't know what it is and all, then you can give it on alternate days.
Statins, yeah. She's asking if there's any pharmacotherapy for menopause other than estrogens.
Well, you know, there are all these non-pharmacological things like soya, which contains plant estrogens. And then there are some other things also. What are they in the West? Phytoestrogens, that is your soya. So they say, but I don't think they're that effective, but it's a non-pharmacological. So
In pharmacology, the one drug that I know is, Kumar will corroborate, paroxetine, 12.5 milligram,
oh,
has been approved for, by US FDA, has been approved for menopausal symptoms, especially hot flashes.
Oh, okay. I learned that today. Thank you.
Somebody wanted to ask a
But
question
that's
there.
the drug paroxetine, which is
SSRI.
the worst of the SSRIs. No, it's the worst of the SSRIs,
Yeah,
isn't
it
it?
causes the maximum weight gain.
Maximum, yeah.
Weight gain amongst the SSRIs. For how many years after menopause?
Anytime after menopause, but interestingly, and I don't know what's the answer to that, it's menopause maybe have happened at 50, but the symptoms will come on at 75. So I think it takes that time. There is still a little bit of estrogen coming out from the adrenals, and you know, the other thing is they say if you have a lot of fat, the estrogen, whatever little is being produced, is deposited in the fat. So I'm very happy about that part of it. So
Dr. Vibhagar,
yes, no prophylaxis.
I'll repeat. He's asking in a person who took HRT when HRT was kind of at the rage, and now she is 70. The patient took HRT for, say, 5 years at the age of 40. Do we do any monitoring at the age of 70 for side effects of HRT?
No, basically we're looking at cancer and deep vein thrombosis. No, once they've stopped it, the vulnerability goes down pretty fast.
Yeah, Dr. Lopa. She's asking about contraindications to vaginal estrogen in patients with atrophic vaginitis. Any precaution to be taken?
See, they used to say that if even any malignancy in the breast also, certainly no systemic estrogens, but I've heard some people talk about vaginal estrogen, but then I've also heard that it's quite okay. I think it's quite okay. So there are no real contraindications.
Yeah, doctor, you want to ask? She's asking if somebody was started at a young age, say 30, 35, 40, because of a very strong family history and high LDL, and now the patient has survived somehow till the age of 75, and the LDL is still high.
There you must continue.
The patient has survived because of the statin.
Yeah, there you must continue.
Yes, sir. what do you do for menopausal women or perimenopausal women, prevention of osteoporosis or osteopenia? What are the methods that we can
One
use?
important thing is, the recommendation is after the age of 65, every woman must have a bone mineral density done. DEXA scan is the most.
65.
65. Not at menopause, unless they have an indication like they, of course, if they've had a fracture, then they've already got osteoporosis, a fragility fracture. But if they are okay, they don't want you to do the BMD too early. They want you to do it at 65 because research shows that that's when, because not everybody is going to get osteoporosis. That's when is the maximum chance that osteopenia will become osteoporosis. So for some reason it's 65. But you might, if there's a strong family history, might, and of course, if you've got a Caucasian patient, they are most vulnerable, then you might want to do it earlier, but the recommendations say 65. So if there's osteopenia, that means it's above minus 2.5. Now, I've known one doctor who, for one of my family, it was minus 2.4. And so said, it's not minus 2.5, so you're okay. I mean, he should have started her. And she developed a fracture the following year. He says minus 2.4. So, but the cutoff limit is given. So if it's 0 to minus 2.4, technically, the osteopenia, they must have good calcium and vitamin D. Whether they are deficient or not deficient, they should have it. The understanding is that vitamin D is, of course, supposed to be one of those wonder vitamins which cures everything from tuberculosis to heart disease to everything, and also improves muscle strength, and it has been shown to prevent falls. Okay, they say the study is flawed, but it does prevent the bone, as we grow older, the dynamic equilibrium of bone deposition and bone resorption, which is perfectly matched. In the elderly, it is not. So bone resorption is a little bit more than bone deposition. So everybody, and then when the estrogen goes off, it's catastrophic decline. So yeah, you do need to give vitamin D and calcium to slow down that resorption thing a bit more. But please, people are not looking at osteoporosis. They are not giving the bisphosphonates. They're waiting for people to get fragility fracture. Once a patient has a fragility fracture, don't do the bone density, please. Just give it.
May I ask you about your take on bisphosphonates versus the newer drugs that have come?
The bisphosphonates are the time-tested ones. I agree. There's so much of hype about this upper GI business, and be standing and take water, and I've never come across a single person, but for legal purposes I make sure that that is written in black and white, and I have taken many patients through weekly alendronate, which is the lowest of the lot. Ibandronate is monthly. It all works out at the same cost, and so all the bisphosphonates, I have great faith in them. There was only one lady, but again, because I don't have records, I don't know, one lady, frail, the perfect person to get a fragility fracture, started on alendronate, 2 years she had it, the 3rd year she fell and broke neck of humerus. So she came and thanked me and said, I might have had neck of femur, but because of your drug I only got humerus. So, which is not really true, but I also believe in it. So I believe in bisphosphonates. What I don't believe in is the use of teriparatide.
Rampant use.
And this is a pure example of, to me, pharma. It's so expensive, and orthopedic surgeons love it, and they have one advantage. You cannot give bisphosphonates after a fracture or after a surgery for a fracture, because it prevents the bone deposition process, you see. So, and that's why we say, if you've got to have a dental surgery, please finish that off, then start the bisphosphonate. If you're already on a bisphosphonate and you have to have tooth implants or something, you must go off the bisphosphonate for 3 months, let your bones soften up during those 3 months, then you do this, otherwise you'll get osteonecrosis of the jaw. Because the bones actually become brittle and they fracture. In fact, when you're on alendronate, the subtrochanteric fracture can occur due to that. So it's a dicey thing, but teriparatide is one drug, it's a parathormone analog. You can give it immediately after the fracture. It does not harm the callus formation, does not hamper callus formation. However, its expense is phenomenal, 15,000 a month, and bone pains and other side effects are there. And when I asked my classmate who runs a top-notch orthopedic hospital in Coimbatore, 2 kilometers from where I am, I said, David, why do you guys talk about osteoporosis in your conferences? He said, why should we? We shouldn't, because we won't get any. So, orthopedic, but they love this drug because it can be given. The other thing which I like to give is nasal calcitonin. Immediately after a hip fracture, you can't give it for a long time, only 2 months, and it does help with the pain. So when I was working, I insisted with my junior orthopedic colleague whom I could force him to do things. He didn't want to. I have to see every hip fracture. He said, no, but you'll take away my fees. Patient will have to pay you also. So I said, okay, you pay me only half the fees. Because hip fracture actually should be managed by a geriatrician, and the orthopedic consultant is only a technical plumber in that episode. Everything else around the hip fracture is in the purview of a geriatrician. This is where we need specialist geriatricians. Because the pain, what caused the fall in the first place, is the thing to look for, because he's going to go out of the hospital and fall again. Okay? So these are things they don't talk about. So yeah, many hospitals overseas have an orthogeriatric sub-department. Where the geriatrician manages everything, orthopedic person just comes and does the surgery and goes away. So the whole thing about anticoagulation during the geriatric surgery, during the hip surgery, they refuse to give it. I have to force them to give it. Sometimes they come out from the operation theatre before going in, and I pull them out and say, delay the surgery for 12 hours while I start off the anticoagulant. Because they're scared. All surgeons are scared of anticoagulant. I feel for them, because I'm not the one doing the surgery. They're the one who's got to face the bleeding. So, these are all very complicated issues in an elderly person. So many elderly people die of pulmonary embolism post-surgery, and nobody bothers about it. But having been in hospital practice for elderly for the last 7 or 8 years, I have seen enough of it to know that this recommendation of giving anticoagulants is a very good one in elderly.
Also, there is now a statistic which says that hip fracture reduces lifespan. Is that true?
Yes. Oh, yeah. Yes. Even if you don't correct the hip fracture, of course, don't operate, it will die very quickly. The immobile pressure, so perfect. Even if you correct it, the lifespan is shortened. I'm not sure by how many years, but the mobility never comes back to normal. Some people do get away, but the majority of them don't. It's also because our physio, our aftercare, especially in India, is abysmal. We have, Coimbatore is a place for orthopedics. People from big orthopedic hospitals in Chennai come to Coimbatore for opinion and get operated here. We've got standalone orthopedic hospitals. Even they will operate on the person, send the person home after 1 month. The dinner plate size of ulcer would come to me. Dinner plate size. So I used to talk to them and say, what are you all doing, So I haven't sorted out the problem. We have to have teams, So, yeah, hip fracture, pressure sores, these are all very big topics in hospital medicine. So the most important thing is prevent it, look for osteoporosis. What I saw in the UK, I was just fascinated. I went with the physiotherapists and occupational therapists. They have home visits for every patient who falls. Because the state is paying for it. They have to prevent the next fall. So they go to the homes, they ransack all the rooms, whip out all the carpets, raise all the chairs, make the bath more friendly, and guardrails, what all, because most of them fall down the steps, and you won't believe it, on the fair skin, looks like they're tattooed from top to bottom, so much, as they roll down the stairs. And so the house is made safe. So we have to prevent falls at all costs. So it's not just looking at their propensity to fall, but the environment, lighting, staircase, handrails, making them use assistive devices. This is the most difficult thing. I thought it's only Indians, but it's all over the world. No older person. If I ask any of you to kindly use a stick and walk, you will just outright refuse me, okay? Because it's a stigma. We have to get over the stigma, and I envisage a day when our pavements will be so friendly for elderly people. Everybody will be having a stick and a walker and walking happily, because elderly people need that extra support. You know, you can't afford to have a fall. So please promote assistive devices in your patients, and always have I don't know how many of you have the advantage of a physiotherapist easily available for elderly persons. Don't just give them the stick. They have to learn how to walk with the stick, which hand to use the stick, how to use it. And once you have given them the stick, in the next visit, if they come without the stick, you know. Yes, yes. So once I sent a patient, I said, please madam, use it outside, because they said it's in the boot of the car. So the younger person went, got the stick, and when she entered, I took a video of her as she was just to make the point, you know, not to humiliate her or anything like that, just to make the point that there's nothing wrong in having an assistive device. It's very important.
So having said that, we will be sending you some pictures of assistive devices that are available in Mumbai with their costs and everything. And I think we should be promoting that more and more. Yeah, doctor. Another drug that is used for osteoporosis currently is denosumab. Do you have an opinion?
I think it's a very good monoclonal antibody to be given, and it's very expensive again, I think 16,000, but it's superior to even zoledronic acid. Zoledronic acid is once in a year. I hesitate to give that, but because, you know, you can't just give it in your clinic. I think you have to, they do say to come and be in the casualty. But if you can look after them, they have some bad reactions, not fatal reactions, but some difficult reactions. So, yeah, it's much better. I have no experience with it, but I understand that it's quite good.
We go to the next, immobility. Immobility, just one thing that they would love to know is about prevention of bed sores. Give them some tips on how to prevent bed sores.
But of course, bed sore would happen in somebody who's totally immobile, cannot turn, say, after a stroke and things like that. But other forms of immobility, minor forms, are in people who, you'll be surprised, but there are many people, and you just ask them the history. What do you do all day? This is one gimmick I employ when I'm not able to understand what the patient has. They're complaining of this, that, and all kinds of things. So I say, okay, tell me from the moment you get up in the morning to the moment you go to sleep, what do you do all day? And they'll say, I have breakfast, then I do something, then I do the puja, and then I have my bath, and then I lie down. By then it's 10:30. And they keep lying down till they have their lunch. And what do you do after lunch? Then I have my after lunch sleep. And so they're actually sleeping all day. So I say, now what about going for a walk? They've never heard the word, and they say, I'm scared, there are dogs all over, and cars are coming, and you know, people live in such surroundings that they cannot go for a walk. But I tell the relatives, you have to find the time, and you have to, because fear of falling is a big thing. So basically what I'm saying is, immobility, not to the degree of pressure sore, but just sitting around. One person tells me, I do the cooking and I cut the vegetables. I said, that's not exercise. Exercise means a regular contraction of the muscles at a particular pace. I said, look at me. I'm sitting and seeing patients for 8 hours. It's not exercise. You know, I'm not exercising my muscles, it's exercising my brain. So that distinction between work and exercise is very important, and they must have aerobic exercise, to be limited in those who have cardiovascular and respiratory disease, no doubt. But if they have those, then programmed with the physiotherapist to see how the oxygen saturation is when that's required. But for the average elderly person, yes. And you must have a leaflet. I don't know whether you have it. I have a leaflet, which I've just taken off the net, where I give to every patient who is like wheelchair bound or can get up and go around somewhat. So there is a set of exercises they must do to keep the conditioning of the muscles. If the muscles are deconditioned, they just melt away faster, and number two, muscle cramps will come. So what you have to do, there's simple exercises. You know, for every muscle group, abductors, then like this, rotators, then for the hip flexors, extensors, stand up, hold the chair and just extend your leg, or bend, very simple exercises. Please do them for 5 minutes every day, 3 times a day before your meals, not after your meals. And so you get that into a program. Nobody does it. But if they do even once a day, it exercises all the muscles they contract. So some form of regular exercise has to be done, and the family members have to help them, motivate them, whatever. So deconditioning of muscles is a very important issue, and falls happen because of that. And when it comes to pressure sore, if you are caring for bed-bound elderly people, in the hospital it's extremely common, and that's all because of poor nursing care. I only blame the nurses for it. Because when I started off as a junior lecturer in CMC, I have seen the worst bed sores ever known to man. I have seen the head from the trochanter, the trochanter come. I mean, I could see the trochanter. And then finally, I have seen the most miserable. By the time I retired, I never saw a bed sore. Okay? Partly because the patients were also better. I never saw a bed sore. Because the nursing protocols had become so excellent, there was an hourly turning of the patient. You can have air bed, water bed, alpha bed, whatever you say, but you still have to turn the patient. You still have to turn the patient. And it's right through the night. And then you know how to maintain that position. So now in every nursing thing, at least in GKNM hospital, we had right side, left side, oblique decubitus, supine, prone, everything was there, all nicely ticked off, never done. Okay? It was just ticked off. So, one had to go there and say, okay, if you turn the patient, where are the pillows? Oh, there are no pillows. Obviously, you haven't done it. So you see, point I'm trying to make is, you put in any rule, you also have to make sure that it's followed and not just written. And it's a laborious process. But once you get the hang of it, it's fun. I have gone home visiting and seen the most awful pressure sores. And there is no need to have them, but it is not easy till somebody finds out a better way of this. But alphabets do help.
So important message here is the prevention is hourly turning of the patient into various positions. Airbed laga diya aur fir kuch nahi kiya has no meaning. You have to turn the patient. So family has to be involved at home.
Yeah. And there's this thing about, there's something the sisters used to tell me in Coimbatore, wasa musa. So what is wasa musa? It sounds very interesting. So it's some kind of a gel which they used to put on the patient and say, oh, wasa musa laga diya, now ella nalla irukuduma, don't worry and all that. But that's all rubbish. There is something to do with nutrition. Good nutrition. They say pressure sore is one way that you detect the NABH, NABH, no? One of the ways they test is how many pressure sores you've got. So we had a pressure sore website where you had to put it all in. And nutrition, it's a multi-dimensional, multidisciplinary approach. The nutritionist has to come in. Unless you have good, healthy tissues, you will get. In the UK, in the hospital that I work, they have something called the tissue viability nurse. They also had the we used to call her the incontinence nurse, but she said, I'm the continent nurse. Okay. So these are this role of elder care was given to the nurses who are better, and they went round the whole hospital, and whether they were called or not, and they had to check every patient's continence, they had to check every patient's skin of the sacral region or the thing, whether it was okay or not. So it needs that kind of a thing. Only nurses can do it, again with dietitians, then surgeon has to be involved, and finally it's the doctor who is responsible if there is a thing. So it's a hard business, but it's something when we got our degrees, That is something we signed up for, so it is our duty.
The last topic of the day, I realize that we are now only 15 minutes away. So last topic of the day is the cognition part, dementia, delirium, both. She was keen to talk about delirium in the elderly because it's also a treatable problem. So tell us about delirium.
So just before that, can we just talk about memory? Sure. Because everybody loses memory as we grow old, and the fear is that we're going to have dementia. So there is a normal memory impairment, and there is a dementia. We're not going to talk about types of dementia. But in between, there's something called MCI. Mild cognitive impairment. Okay, that MCI in me does not allow me to say mild cognitive impairment. Now with the help of my friend here, yeah, MCI. So in MCI, how do you differentiate? So the example that I give is, many people, they're so worried, they say, doctor, I just can't remember anything, you know. I'm also worried, I can't, where to leave the keys, this, that and the other, and I was so good at recalling this, that and all. So the dictum is, which is not 100% dictum, if you're worried about dementia, you don't have it. If you have dementia, you're in blissful ignorance. You don't know that you don't know. But we are talking about advanced stages, okay? So the guy goes into the shop and he says, oh my God, I didn't bring my list. My wife sent me to buy this, and he rings up his wife and she scolds him, said, just asked you to buy 5 things and you still don't remember it and buy them. Whereas the guy with dementia will go and say, what is this lovely place that I've come to and all that and this thing, and he gets into his car, takes 1 hour to get back because he's forgotten the way to the house. So he's dementia and the other one is normal memory loss. So, but still, anybody who's worried about it, and even anybody who's not worried about it, all patients above the age of 60 must have a screening test. And I think you all know that there are many hundreds of screening tests. Just get familiar with one of them, which is fast to administer. I find the mini-cog is a very fast thing to administer. So basically you give them 3 unconnected words to remember. Keep it in your mind, make sure they understand it, repeat it after you, then do something else, check their blood pressure or something, and then remember, you have to remember to ask them. One patient keeps coming in and every time I say, what's wrong with you? He said, chair, ball, pen. Because that's the question he knows he'll be asked. So, and another patient told me, doctor, you forgot to ask me. Okay, so aside from all of that, so mini-cog, if they recall all 3, they passed. If they recall 2 out of 3 or 1 out, if they recall none, they are obviously got problem. 1 out of 3 or 3 out of 3, then you must do the clock drawing test, okay? And I don't know how this clock drawing test is not something which all Indians can do. If they've never been interested, never coming for seminars, never called by Tushar, didn't have this thing. The person in the village only wants to know, is it morning or night? That's all they want to know. They've never seen a clock. So I'm just taking extremes, but for average urban practice, a clock is all right. But after this generation, this millennial generation, they don't look at the clock. They just have digital. So we'll have to change all that. So once the screening test is normal, no one have to proceed. If it's abnormal, then you must do the other important tests. And people all over the world, according to the literacy standards and all that, have come up with other types of tests. The test called MMSC is useless for our Indian population, but because we don't have a better test, we do it. So there is a group in India who's trying to do for the rural what test to use, this thing. Then we use translation. So basically, if on the MMSC you have a poor score, then you say, okay, this is definitely dementia. But delirium also can give rise to a lower score. So when we say dementia, it has to be there for more than 3 months and 6 months. And it has to deteriorate. Whereas delirium, you will score badly, but it may come back to normal. So we're not talking about that. But you actually asked me to talk about delirium. So delirium is something which every general practitioner should know something about and should be able to smell it and diagnose it, because it needs treatment, it is treatable. So how it's different is, there is a global cerebral dysfunction. in delirium. And usually what will happen is, if there are two main types, an agitated delirium and a quiet delirium. If it's a quiet delirium, you may miss it. The person is just sitting there not saying anything. Okay? He may be just a laconic, shy kind of a person, but you could miss it. Whereas the one which agitated, hallucinating, seeing donkeys here and something there, very easy to diagnose. Their behavior is abnormal, their attention span is low. You try to ask them, so what happened yesterday and all that. So, in 1948, something, then he stops talking. He's not answering your questions, poor attention span. So, he may be looking otherwise normal. So, there are many of these things, and then you'll find a fluctuation in the sensorium. Certain part of the day they'll be all right, and especially at night, even in dementia, there's a sundowning effect. At night, they become agitated, misbehaving, doing all kinds of things. So morning time, they're normal. So this sleep-wake cycle also will be reversed. They will sleep during the day, be awake at night. So many of these things may tell us that the person has, and they'll be disoriented. You just check a person who's otherwise well and say, so what is the date today? And he'll say, it is 10th or 12th, it'll be all wrong. What day is it today? I know it is, but I don't know. So they'll be talking to you like this, but they'll be totally disorientated. And one person, I went to the house to visit and I said, so who is this person standing in front of you? That person got so annoyed with my question. Why are you asking that? She knows I'm Padma. So he said, Padma dana. I said, wait. Then I got another person and said, who is this? She couldn't answer. So this person was suddenly very angry. How? She knows me. So you see, the family member also may not be able to recognize. Now, the question why they had called me was, she goes in the night to the bathroom, fills it up with water and sits in the bucket. So she was actually dementia, but it had happened suddenly. So it was a delirium superimposed in dementia, which is very difficult to diagnose. So anyway, what I'm saying is, these are the things: fluctuation, it can be agitated with hallucinations, disorientation in time, space and person, inattention. Normal person, older person will be able to carry on a decent conversation with you, whereas a person with dementia. So that is one. There are many scales also, abbreviated mini mental and all those things. I saw in the UK, they were so good at it, just like they take the blood pressure. They'll be saying, okay, Mr. So-and-so, so what time of the day is it and all that. As part of the examination, they said he's got 4 on 10. He's got delirium. They were so good at it, I could never come to that level. So somebody has to do that. And then in the casualty, in the emergency, there's another way of doing it. We won't go into all those details, confusion assessment score. Those who are interested, or when we are studying these things in detail, we can look at all those things. So why is delirium so important? Because a person in delirium has a higher mortality. So after hip surgery, if somebody goes into delirium, his mortality is higher. So you have to treat it. There is no treatment for delirium. We only have to find out what precipitated it. So if you know the precipitating factor, remove the precipitating factors. So the precipitating factors are any new drug, like we just said, diuretics and all those things. Any new drug added, any infection, okay? So you can see how infection actually affects most of these. So any infection can give rise to delirium. Any new drug, we already said. And then electrolyte abnormalities. So a delirious person, hyponatremia is the most important one of them. Then certain cerebrovascular diseases, for example, like a small stroke, good. And if the stroke has produced a hemiplegia, then it's very easy. But small subcortical infarcts can happen in these patients. For that moment, for 3-4 days, they are very unwell. There are no deficits that you can pick up even if you're a good neurologist. You can't be doing MRI scans for everybody, you see. So these are the causes of delirium. So everybody must have electrolyte done, especially if it's an acute delirium, and then you have to correct that. And as far as possible, you have to support the patient by making sure that they come back to orientation. So if they don't have their glasses, especially they get admitted into hospital, you see, withdrawal of benzodiazepine, they get into hospital, and then so we say, where's the specs? Go get the specs. They must wear this bag. Put a calendar. Iniki tingal kalam irukku. Today is Monday. Yesterday was, and you quiz them. So you train them again, make them hear, keep talking to them, explaining nutrition, all those things, hydration. And so that's the treatment for delirium. If they come out of it, it's fine. Most of the time what happens is when they have agitated delirium in the hospital, because the neurologists will be called, they'll be put into an MRI machine and they'll get more delirious, start shouting, this, that and the other. So I've had instances of pulling them out of the MRI machine. I've had people ringing up from America and saying, "Madam, we can afford MRI. Why you stopped the MRI?" I said, "Because he got a urinary tract infection and he developed abnormal behavior. Please don't do an MRI." So these are the kind of things we have to battle with. And then when they're very agitated, you do have to give them drugs. So the drug that is given is benzodiazepine. Benzodiazepine causes more delirium.
Like we give in alcohol withdrawal, delirium, same.
Yeah, there it's all right. There we give chlordiazepoxide, but even benzodiazepines have been allowed, but because of the addictive potential of benzodiazepines, and already a person is addicted to something, they've got that, we try not to use benzodiazepine, at least I didn't. We used to use chlordiazepoxide, which is again a benzodiazepine in a way, but doesn't cause addiction so much. So for agitation, you may have to. So what we try to give for these people is haloperidol. Haloperidol, if they are very agitated. Now, I had one patient who was going to beat us all up. We ran out of the room and we had to call a male person who immobilized him from the back. And I told the sister, quickly get the haloperidol ready. I'm not going to come in. The assistant held him from the back. The nurse jabbed in 5 milligrams of haloperidol. He slumped like this, we put him in the bed. Then you have to maintain it. So most of the patients are not going to be so bad. So 0.25 milligrams of haloperidol, or Serenase, what you call, 0.25 to be given once or twice, knowing that haloperidol is going to give rise to extrapyramidal syndrome and is going to become stiff after some time. So you have to give very, very low doses, don't give in a regular dose. Risperidone also for agitation, they say is okay, 1 milligram, better than this, but you have to watch out for the extrapyramidal syndrome. So just agitation. These are the things we also give for patients, antipsychotics, which we also give for patients who are having behavioral and psychological disturbances or behaviors in dementia, quetiapine, other psychotropics we use. But in elderly, they say the least amount of antipsychotics is best. Mortality is higher. Give it for the moment. Try to withdraw as fast as possible. Unless, of course, they've got a psychosis, full-blown psychosis, for which they might have been on valproate or something for many years. Try not to give these antipsychotics. So the neurologists and all will give them maximum doses of benzodiazepine. We try to work with them and withdraw them. So
one important takeaway from here is that in a patient who is acutely delirious, very violent, then the dose she mentioned, 5 milligrams, not 0.25 for that. 5 milligrams for the acute episode,
yeah, for the injection.
Intramuscular injection.
Dose is higher.
Whereas the oral maintenance dose, what she said for a few days, was the lower dose of 0.25 milligram tablet. So we should not confuse doses there. If you want to give haloperidol, haloperidol of course is Serenase, that you all know.
You can give 2.5 if you want injection. Injection is always higher. Which, unlike other drugs, usually the oral is higher. Yeah, this is the other way around.
I think we'll end here, and what can I say? Thank you so much for coming. She's come from Coimbatore only for this. There's no other reason for her to come here. We found some reasons, but otherwise this was the only indication for her coming. And I'm so grateful that you came. I'm really grateful.
If somebody offers to pay you airfare, put you up in a nice boutique hotel and they say, how can you refuse? Sorry?
Ahmedabad is closer to Mumbai, and he said,
why did you come here?
Why
because
did you
hate cricket. Thank you
Thank
all
you so much. Big round of applause again for her. Thank you so much.
I've enjoyed being here because of your reaction.